Welcome to the Deep Dive. Today, we're tackling a topic that, well, it impacts millions, over 8 million people worldwide, in fact.
Yeah.
Type 1 diabetes.
Mm.
It's this silent, constant battle. And, despite all the medical advances we've seen, managing T1D is still incredibly tough. Often comes with really serious, sometimes life-threatening complications.
It really does. It's a daily grind for so many.
So imagine if that relentless struggle, the constant checking, the fear of lows, the injections could be, well, maybe not gone entirely, but dramatically reduced, maybe even eliminated for some.
That's the big hope, isn't it?
Exactly. And that's the promise behind something called Isletsfor. It's a new therapy using stem cells. And it's the focus of this really quite groundbreaking study in the New England Journal of Medicine.
A very prestigious journal, yeah. Signals the importance.
Right. So our mission today is to really dig into this research. What is Isletsfor? How does it supposedly give the body back its own ability to control blood sugar? That's the key, right? Addressing the root cause.
Absolutely. Fixing the underlying problem, not just managing the symptoms.
Okay, let's unpack this.
Yeah, this study, it really could be transformative for how we manage type 1 diabetes. For decades, the focus has been on getting insulin in from the outside.
Right. Injections, pumps.
Yeah.
Life-saving, obviously.
Totally life-saving, but it has limits, big limits. And this study suggests, moving beyond that, trying to restore the actual physiological process that's been lost.
So it's not just about the what the drug itself, but the why.
Yeah.
Why is this such a potentially huge deal?
Exactly. We want to get into why this could fundamentally change what it means to live with type 1 diabetes. It's a glimpse into a potentially very different future.
Okay, let's start with that daily reality. What is life with T1D actually like? Our sources paint a pretty vivid picture. We said 8 million people worldwide.
A huge number.
And the root cause, it's devastating.
Yeah.
It's the body's own immune system attacking and destroying the insulin-producing beta cells in the pancreas.
Right. These little clusters called islets. The immune system just wipes them out. Autoimmune.
So the body turns on itself, basically. And the result is, well, you can't control your blood sugar anymore. Dysglycemia, they call it.
Which leads straight to needing insulin from outside. Exogenous insulin. Lifelong dependence.
Lifelong. Think about that. Every single day, monitoring, calculating carbs, activity, stress, everything affects it.
Everything. It's a constant mental load. Before every meal, every snack, exercise.
Yeah, planning everything around it. Takes away a lot of spontaneity, I imagine.
Definitely. It dictates so much of your life.
And even with all that work, hitting the goals is tough. The official recommendations, like from the American Diabetes Association, they say aim for an HbA1c below 7%.
Right. That's the average blood sugar over a few months. And also spending most of your time, like over 70% in that target glucose range, usually 70 to 180.
But the reality,
Yeah.
the sources say around 75% of people with T1D don't hit that HbA1c target.
Yeah, 3/4. Despite their best efforts, despite the technology we have now.
By not hitting those targets,
Yeah.
that leads to increased risks down the line right now.
Big time. Those long-term complications, they're serious. We're talking microvascular, macrovascular, basically damage to blood vessels, big and small.
So that means what? Eye damage.
Retinopathy, yeah, can lead to blindness. Nerve damage to neuropathy. Pain, numbness, affects organ function sometimes.
Kidneys.
Nephropathy, kidney disease, potentially leading to failure, dialysis, transplant.
Wow. And cardiovascular disease.
Higher risk of heart attacks, strokes. And sadly, yes, even early death. It's a constant battle against these future possibilities.
It's grim. But there's also an immediate danger, isn't there? Hypoglycemia.
Severe hypoglycemia. Yeah, that's the flip side of taking insulin. Too much insulin relative to your needs.
And your blood sugar crashes, dangerously low.
Exactly. It's a true medical emergency, not just feeling a bit weak. We're talking loss of consciousness.
Which could lead to falls, car accidents.
Seizures, coma, even death. It's terrifying for patients and families.
And the participants in this study, they have a specific problem with this, right? Impaired awareness of hypoglycemia.
Yes, that's critical. Their body's warning signals just didn't work properly. They couldn't feel a low coming on until it was already severe.
Wow. So no warning.
Little to none. And they had to have had at least 2 severe events in the past year to even get into the study. These were really high-risk individuals.
The source says their risk is up to 6 times higher.
Up to 6 times, yeah. Compared to someone with normal awareness, it's an incredibly vulnerable group.
So current treatments weren't enough for them.
Clearly not. And that highlights the limitations even with the best available tech. That narrow therapeutic window for insulin is just tricky.
Meaning it's easy to overshoot, give too much.
Very easy. The line between enough insulin to control sugar and too much causing a dangerous low is incredibly fine. Dose adjustments are always a bit risky.
Like walking a tightrope.
Constantly. And even with advanced tech like automated insulin delivery systems, the so-called artificial pancreas.
Yeah, the pumps with continuous glucose monitors.
Right, the most sophisticated approach we have. Even with those, about 35% of users still don't meet that HbA1c target of less than 7%.
Still a third.
And maybe more worryingly, about 9% still report having recurrent severe hypoglycemic events, even with the best tech.
So even the best isn't perfect.
Far from it, because the fundamental flaw, as the source puts it, is that none of these methods have the precision, accuracy, and reliability of physiologic glucose regulation.
Meaning they can't replicate what a healthy pancreas does naturally.
Exactly. Your pancreas is constantly monitoring, making tiny adjustments in real time. Insulin, glucagon, it's incredibly dynamic. Our current tech is still, relatively speaking, kind of crude compared to that. It's reactive, not truly proactive in the same biological way.
Okay, what about actual beta cell replacement? Like islet transplants or pancreas transplant?
Well, they exist, yes. But they have huge hurdles.
Like finding donors?
That's the biggest one. Limited organ availability. There just aren't nearly enough donors for the millions who could potentially benefit.
And the quality varies.
Yeah, islet quality from donors isn't consistent. And often, you need cells from multiple donors, multiple transplants, to get a good clinical outcome. That adds complexity, risk.
So not really a widespread solution.
Not at all, only for a very small number of people. Which really brings us back to that question. How do we get something more consistent, more reliable, something that actually restores that natural physiological function?
And that's where zimislecel comes in, this novel approach.
Right. The big idea here is stem cells.
The pluripotent stem cells, the body's master cells, right?
Exactly. They have this amazing ability to become almost any cell type. So the goal here is to guide them to become those specific insulin-producing beta cells that were destroyed.
Kind of like growing replacements in the lab.
Basically, yes.
Yeah.
Providing a renewable source. And the preclinical work, the studies before this human trial, showed a lot of promise.
What did they show?
They showed you could reliably make functional beta cells, the insulin ones, and also alpha cells, the glucagon ones you need both for good control. And crucially, these lab-grown cells could actually reverse diabetes in animal models.
So it worked in the lab, worked in animals. Next step, humans.
That's the leap, and that's what this study is about.
So zimislecel itself, or VX-880, the source calls it allogeneic stem cell derived, fully differentiated islets. Let's break that down.
Okay. Allogeneic, that means the cells come from a donor, not the patient themselves.
Why is that important?
Scalability. It means you could potentially create one well-characterized cell line and use it to generate treatments for many, many patients. It gets around that donor organ shortage we talked about.
Okay, so one source for potentially thousands of people. That makes sense. And fully differentiated.
That's key, too. They aren't just injecting basic stem cells. These cells have already been guided in the lab to become functional islets, ready to sense glucose and secrete hormones. They're specialized, ready to work.
Like pre-programmed mini organs.
Kind of, yeah. Functioning islet clusters.
So the researchers' hypothesis was, put these cells into people, similar to how they do islet transplants.
Right. Infuse them into the portal vein, which goes to the liver, where islets typically engraft.
And they hoped this would lead to, what? The body making its own insulin again?
Endogenous insulin production, exactly, is something T1D patients completely lack, plus better glycemic control overall.
And crucially for this group, stopping the severe hypoglycemic events.
Eliminating them, ideally, and the ultimate goal for many.
Insulin independence. Getting off injections or pumps altogether.
That's the dream scenario for so many patients.
And this ties back to that idea of an inexhaustible supply from stem cells, overcoming the organ shortage.
Precisely. It's the broader promise of stem cell technology creating replacement tissues on demand for diseases where we currently just don't have enough solutions, like diabetes, Parkinson's, heart failure. It opens up huge possibilities.
So moving beyond just replacing insulin shots.
Yeah, it's about reestablishing that natural feedback loop. The body sensing sugar and responding appropriately. Insulin shots, even pumps, they just can't fully mimic that dynamic biological process.
It's about restoring that physiologic function.
That's the core concept.
Okay.
Not just controlling glucose numbers, but restoring the body's natural, elegant way of doing it. Responding instantly to meals, to exercise. That dynamic control is what's missing.
And validating this in humans, that's the big step here.
It's huge. Taking it from the lab bench through animal models and showing that stem cell-derived islets can actually survive and function effectively in people, it's a major milestone for regenerative medicine.
Okay, so let's dig into how they actually studied this, the VX-880-101 forward study. What was the design?
All right, so it's described as an ongoing, open-label, 5-year, phase 1 to 2 study. Open label meaning everyone knew who was getting the treatment.
And it's already moving into phase 3.
Yes, which is a very positive sign. Phase 3 is usually larger, aiming for confirmation before potential approval.
Good. Now, the participants, we know they were 18 to 65, had T1D for at least 5 years, and crucially, had that impaired awareness of hypoglycemia and at least 2 severe lows in the past year.
Right, a very specific high-need group. And they were all insulin dependent with no detectable C-peptide, meaning no natural insulin production at the start.
And they were already getting good standard care, right, using continuous glucose monitors.
Yes, that's important. These weren't people neglecting their care. They were doing the best they could with current tools, and it still wasn't enough to prevent severe lows or achieve optimal control. They represented that critical unmet need.
Okay, how is zimislecel actually given?
There were different parts to the study. Part A got a half dose, 0.4 billion cells. Parts B and C got the full dose, 0.8 billion cells.
And it was infused. Where again?
Into the portal vein using a catheter. It was a single infusion, took about 30 to 60 minutes, using gravity to help the flow.
And they staggered the dosing at first for safety.
Yeah, in parts A and B, they waited at least 29 days after one participant was treated before treating the next, just to monitor safety carefully in those early stages. Later, in part C, they could dose concurrently.
Makes sense.
Yeah.
And the immunosuppression, absolutely vital, you said.
Absolutely. Because the cells are allogeneic from a donor, the patient's immune system would attack them without it. So they got immunosuppressive drugs induction before the infusion and maintenance therapy afterwards.
And specifically, glucocorticoid-free immunosuppression.
Yes, and that's a really key detail. Standard glucocorticoids like prednisone can actually be harmful to beta cell function, especially when blood sugar is high. They call it glucotoxicity. Avoiding them was likely a deliberate strategy to give the transplanted cells the best chance.
Interesting. We'll come back to that. And the results we're looking at today are from an interim analysis.
Right. An unplanned look at the data for participants who'd completed at least 12 months of follow-up as of October 2024. So it's a snapshot, but a very revealing one.
Okay. And what were they measuring?
Yeah.
The endpoints?
Good question. In Part A, the main goal was just safety. But in Part C, the full dose group, the primary efficacy endpoint was twofold: being free from severe hypoglycemic events and having an HbA1c below 7%, or at least a 1 percentage point drop from baseline.
So hitting both safety, no severe lows, and efficacy, good control targets.
Exactly. Really clinically meaningful goals. Secondary endpoints included achieving insulin independence and, crucially, those C-peptide levels.
Right. C-peptide being the marker for the body making its own insulin.
Precisely. Measured with that mixed meal tolerance test to see how the cells responded to a food challenge. Remember, everyone started at 0 C-peptide. Any detection later was proof the cells were working.
And there was oversight. Independent committees.
Yes, Vertex Pharmaceuticals sponsored it, but there was an independent data monitoring committee watching over safety, and an independent group adjudicated all the severe hypoglycemic events. Adds rigor and credibility.
So the design seems focused squarely on those major unmet needs, the dangerous lows and poor control.
Absolutely. It was designed to see if this therapy could solve the problems that current treatments, even the best ones, often can't.
Okay, let's get to the results then. The exciting part. 14 participants completed 12 months, 2 half-dose, 12 full-dose. What was the first big finding?
Engraftment, that was the foundation. All 14 participants showed evidence that the cells had successfully engrafted and started functioning because they all started producing C-peptide.
All 14. That's huge. The cells survived and started working.
A critical first step. But the really dramatic results came from that full-dose cohort, the 12 people in parts B and C.
Okay, tell us about the severe hypoglycemia first, that immediate danger.
This is just stunning, really. 0. No participants in the full-dose group had a severe hypoglycemic event during that whole evaluation period from day 90 to day 365.
0, from having 2/4 per year before.
0. Complete elimination for that period. All 12 met that primary endpoint criteria. For people living with that constant fear, especially with impaired awareness, you just can't overstate how life-changing that is.
Wow. Okay, what about the C-peptide? Proof of insulin production.
Started at undetectable, remember. By day 90, all 12 had detectable C-peptide. The average stimulated level was 424 picomoles per liter.
So a definite response early on.
And it got better. By day 180, the average was up to 1036. And it was sustained by day 365. It was averaging 1274.
So the cells kept working, maybe even improved over time.
Yeah, seems like it. And importantly, all 12 stayed above a key threshold, 100 pimolar peak C-peptide from day 90 onwards. That indicates a durable, functional graft. They weren't just sputtering, they were working robustly.
Okay, what about overall control, HbA1c?
Baseline average was 7.8%. Nobody was below the 7% target. By day 120, just 4 months, all 12 were below 7%. The range was 5.7% to 6.7%.
All of them, that quickly.
All of them. And that control was sustained through the year. The average drop from baseline at day 365 was 1.81 percentage points. That's a massive improvement, clinically very significant for reducing long-term complication risks.
Amazing. And the time and target range, the day-to-day stability.
Baseline average was under 50% time in range. Nobody was hitting the 70% target. By day 150, all 12 were spending more than 70% of their time in range.
Another huge jump.
And it kept improving. At day 365, the average time in range was 93.3%. Just incredible stability.
93%. So almost constantly in the healthy range.
Pretty much. And their glucose variability, how much their sugar bounced around, dropped dramatically too, from 36% down to 20%. Much smoother sailing day to day.
Okay, the ultimate question for many, insulin independence.
This is another remarkable outcome. Insulin use dropped or stopped completely in all 12. The average daily dose decreased by 92%.
92% reduction.
And the big one, 10 out of the 12, that's 83%, achieved complete insulin independence by day 365, some as early as day 150. And they stayed off insulin.
10 out of 12 needed no external insulin at all.
Correct. Complete independence. For the 2 who still needed some insulin, their doses were cut significantly by 70% and 36%, and they still had those great improvements in HbA1c and time in range. So a massive benefit even for them.
These results sound almost too good to be true.
They are genuinely profound. And what's fascinating, as you said, isn't just the numbers, but that it points to restoring physiologic function. The cells are actively regulating glucose, responding to the body's needs.
It's not just managing, it's repairing.
In a functional sense, yes, restoring that lost capability and translating it to the patient experience. No severe lows means freedom from fear. Sustained HbA1c under 7% and high time in range means drastically lower risk of blindness, kidney failure, nerve damage down the road.
And getting off insulin, or even just reducing it massively.
Huge quality of life improvement, less burden, less planning, more freedom, more spontaneity. It's transforming the experience of living with the disease.
What about those 2 who didn't get fully off insulin? You mentioned something earlier.
Right. The source provides important context. Both of those participants received high-dose glucocorticoids shortly after their infusion, which was against the study protocol.
The steroids, we said, could harm beta cells.
Exactly. That glucotoxicity effect might have impaired how well the islets engrafted or survived in those 2 individuals. It actually reinforces how important the study design and the specific immunosuppression regimen were.
So it wasn't necessarily a failure of zimislecel itself in those cases.
It suggests an external factor, the prohibited medication, likely played a role. But even with that, their results were still significantly improved. It really underscores the potential power of this therapy when everything goes according to plan. It suggests a real shift from just hormone replacement to restoring a physiological process.
Okay, incredible efficacy. But we always have to talk about safety. What did the study find there?
Right, crucial aspect. Overall, for the 14 participants, most side effects were mild or moderate.
What were the common ones?
Things like diarrhea was pretty common, almost 80%, headache in about 70%, nausea in 64%. COVID-19 popped up in half, likely just due to the pandemic timing. Mouth ulcers also in half.
Okay. Anything more serious? Like, did anyone drop out?
No, importantly, no adverse events led anyone to discontinue the study. That's a good sign for tolerability.
What about serious adverse events, SAEs?
There were some. 3 participants had neutropenia, low white blood cells that needed longer hospitalization. 2 had acute kidney injury. Other SAEs happened in 1 participant each.
But were these related to zimislecel itself?
That's the key question. The investigators concluded that none of these serious adverse events were related or possibly related to zimislecel.
None. So likely related to other factors. The procedure, The immunosuppression.
Exactly. Which brings us to the 2 deaths that occurred during the study follow-up. We need to be very clear and careful here, using the information from the source.
Absolutely. Transparency is vital.
The first death was in Part B about 19 and a half months after the infusion. The cause was cryptococcal meningitis, a fungal infection.
Okay. What led to that?
It was traced back to complications from an extensive sinus surgery the person had, which involved a skull base injury. Importantly, this participant was also taking those high-dose glucocorticoids that were prohibited by the protocol.
Ah, the steroids again.
Yes. And they were on the standard immunosuppression needed for the transplant. The investigator felt the meningitis was related to the immunosuppression. Infections are a known risk when the immune system is suppressed, but not directly related to Zimislecel itself.
Okay, so a known risk of the necessary immune suppression, exacerbated perhaps by other factors.
That seems to be the assessment. The second death was in Part A, about 30 months after infusion. This was due to severe dementia with agitation.
Dementia.
Yes, but it was the progression of a pre-existing neurocognitive impairment. This participant had suffered a severe traumatic brain injury in a car accident before entering the study.
And that accident was caused by
A severe hypoglycemic event, which just underscores the risks these patients faced before the trial. This death was considered unrelated to the study drug or procedure.
Okay, so tragic events, but not directly caused by the therapy itself, according to the investigators.
That's the conclusion presented in the source. Now, there were some non-serious adverse events that were considered related or possibly related to Zimislecel.
What were those?
7 participants had them. They were mild, transient things, like temporary bumps in the liver enzymes shortly after infusion, usually resolving within a month, mild temporary drops in white blood cells, or changes in kidney function.
And is that unexpected?
Not entirely. The source notes these kinds of mild transient changes have been seen before with the infusion procedure itself and with the immunosuppression used in other islet transplant studies.
So it fits within the known profile of this kind of procedure.
Largely, yes. It highlights that crucial balance we always talk about with transplants, the benefit versus the risk, especially the risks associated with the necessary immunosuppression. The safety profile here seems generally consistent with that context.
Right. So putting it all together, what's the bigger picture here? What does this all mean?
Well, even though it's an interim analysis from a relatively small group, the results strongly back up the main idea. Zimislecel can restore physiologic islet function in humans. That's a huge statement.
And it directly tackles the problems with current insulin therapy.
Exactly. The burden, the constant calculations, the fear, the risks of lows, the difficulty in maintaining control. Zimislecel holds the promise of potentially eliminating or drastically reducing all of that.
Giving people back a level of freedom and safety they haven't had.
A huge amount of freedom. And beyond just T1D, it's powerful proof of concept. It shows we can make functional pancreatic islets from stem cells and use them successfully to treat disease in people.
It validates the whole regenerative medicine approach for this.
Absolutely. So what does it mean? It means we might be on the verge of a paradigm shift. Moving from just managing symptoms to actually restoring function, it's incredibly hopeful.
So the study concludes these results warrant further investigation.
Yes, definitely. That's the crucial next step. Larger trials, longer follow-up, diverse populations. This interim analysis is a fantastic start, but it needs confirmation on a bigger scale before it becomes widely available.
But the potential real-world impact, it's massive.
Transformative. Consistent glycemic control, freedom from severe lows, potential insulin independence. It could fundamentally change millions of lives. Less fear, fewer complications, better quality of life. The societal impact could be enormous, too.
And the scientific breakthrough itself.
Just the fact that we can consistently make functional human beta cells from stem cells and have them work long-term in the body, that's a monumental achievement. It really opens the dive for stem cell therapies for other complex diseases, too. It feels like a new era might be starting.
So wrapping this deep dive up, the core takeaway really seems to be Zimislecel's remarkable potential. Restoring natural insulin production, dramatically improving outcomes, potentially freeing people from daily insulin, and that constant fear of lows. As you've listened, what really stands out to you is the biggest implication here? For patients, for medicine's future.
You know, I think the most provocative thought to leave with is how this could fundamentally change the very definition of living with type 1 diabetes. Imagine it shifting over the coming years or decades from being this relentless, all-consuming daily struggle to becoming a condition where physiological function is actually restored, where the body essentially takes care of itself again. That's a profound shift to think about. Could that really be where we're heading for chronic diseases like this?
A future where T1D means something entirely different. That's certainly something to ponder. Thank you for joining us on this deep dive. Stay curious, keep learning.